Welcome to your meeting with ICM. The interpretation button should appear at the bottom of your screen, next to the Share Screen button. By clicking on the interpretation button, you can choose the language you would like to hear. The interpretation button will then transform this meeting into the selected language. To change the language you would like to hear again, follow the previous procedure by clicking on that same button. By default, you will hear the selected language at 80% volume and the original audio at 20% volume. If you would like to mute or unmute the original audio, click on the corresponding option within the language button. Enjoy your meeting. Bienvenue à votre réunion avec l'ICM. Comme la réunion propose une interprétation simultanée en français, le bouton Interprétation devrait apparaître en bas de votre écran à côté du bouton Partager l'écran. En cliquant sur le bouton Interprétation, vous pouvez choisir la langue que vous souhaitez entendre. Le bouton Interprétation se transforme alors en la langue sélectionnée. Pour changer à nouveau la langue que vous souhaitez entendre, suivez la procédure précédente en cliquant sur le même bouton. Par défaut, vous entendrez la langue sélectionnée à 80% de volume et l'audio original à 20% de volume. Si vous souhaitez couper ou supprimer l'audio original, cliquez sur l'option correspondante dans le bouton de la langue. Bonne réunion. Bienvenido a su reunión de la ICM. Como la reunión ofrece interpretación simultánea en español, el botón Interpretación debería aparecer en la parte inferior de su pantalla, junto al botón Compartir pantalla. Haciendo clic en el botón Interpretación, puede elegir el idioma que desea escuchar. El botón Interpretación cambia entonces al idioma seleccionado. Para volver a cambiar el idioma que desea escuchar, siga el procedimiento anterior pulsando el mismo botón. Por defecto, oirás el idioma seleccionado a un 80% de volumen y el audio original a un 20%. Si quieres silenciar o desilenciar el audio original, haz clic en la opción correspondiente del botón de idioma. Disfruta de su reunión.
Welcome, everyone. You can actively engage in this session through the chat box function. And for any questions you have, feel free to use the Q&A button in the bottom of your screen. We will address your questions at the end of the session. Now I will hand over to Caroline.
Thank you, Bruna, and a very warm welcome to everybody this morning, this afternoon, this evening. It's terrific that you could join us again. This is our third of 5 webinars. I think for some of us, there was a bit of confusion with the time changes in some parts of the world. So our apologies. We hope you have managed to find us. At least 130 people have found the right time. So that's fantastic. Bruna, we'll go to the next slide. So tonight tonight for me, I'm in Australia. My name's Caroline Homer. I'm a professor of midwifery at the Burnett Institute in Melbourne. And with Andrea Nove from Novometrics, I led this study with ICM, which is funded by the Gates Foundation. And we're really happy to be presenting the work for you in this webinar series. We'll go to the next slide. So in this session, we're going to do a bit of a recap of what's happened in the previous 2 sessions that we've had. We're going to talk particularly about quality midwifery care that is recognised by the community. So that's one of the success factors. There are 4 success factors. I'm going to come back to numbers 1 and 2 in a moment, but number 3 is quality midwifery care. And number 4 is interdisciplinary and inter-facility collaboration, coordination, and functional referral systems. And that's a really important part of our conversation in this session. And then hopefully if we have time, like we've had in the other sessions, we'll have a bit of Q&A to go through anything that you would like to ask us. Next slide, thank you. So the midwife-led birth center study, as I said, it was conducted over the last 18 months. It's funded by the Bill and Melinda Gates Foundation, and it's supported through ICM, the International Confederation of Midwives, and we have a fantastic research team and across 4 countries where the case studies were. So Bangladesh, Pakistan, Uganda, and South Africa. And we've conducted a case study in those 4 countries showing that there is no one-size-fits-all approach. So it all has to be related to your context. And we suggest you really think about your context. But there are some universal success factors. And we've been going through 2 of them last week, and we're going to do 2 of them in this session today. The success factors apply to all the countries, but in this session today, you're going to hear from Pakistan and from South Africa. So some of the success factors are pitched at those countries because our colleagues, Razia and Sheila, know those countries the best. But these are universal success factors and are applied to all 4 countries. Thank you, Bruna. And you can see in the left-hand side of the box, the enablers. Last week, we talked about financing and about leadership and governance and unpicked the really important part of those with some examples from Bangladesh and from Uganda. In this session, as I said, we're going to talk about collaboration and quality midwifery care. On the right-hand side of this slide, you'll see the barriers to getting midwife-led birth centers successful. And these are affordability. If women can't afford the models, they're less likely to be successful. If there's no infrastructure, if there's no enabling environment, that's going to compromise quality and safety. If there's limited support or trust for midwives, that is, again, is a barrier. And then if there's poor integration of the MLBCs into the health system, that is a problem. So we hope that when you're thinking about setting up your own MLBCs or strengthening the ones you have, you might think about these enablers and think about how you might address the barriers. Thank you, Bruna. So in this session, as I said, session 3, we have 2 fantastic speakers. Razia Naveed is the from Research and Development Solutions in Pakistan, and Sheila Clow, who's from the University of Cape Town in South Africa. Both Razia and Sheila were integral parts of the research team and led the research in their respective countries. So we're super happy that they can present tonight. So I'm going to hand over now to Razia to take us through the first success factor 3, which is about quality midwifery care. Over to you, Razia.
Good morning, good afternoon, good evening. Thank you very much for your participation. Thank you, Caroline, for the great introduction. I am Razia Naveed, representing Research and Development Solutions, Pakistan. Research and Development Solution Pakistan is one of the country's leading consulting firms, focusing on research, technical assistance, and evidence-based policymaking. In the context of this study, I assumed the role of lead qualitative research analyst. First slide, please. So I'll be talking about the success factor that is the provision of quality care in the MLBCs. So why women, they chose MLBCs over other health facilities? Women chose MLBCs for a combination of factors that encompass financial considerations, the quality of care provided, the physical environment, midwives' reputation, and the accessibility of MLBCs. MLBCs offered a significant advantage by providing essential maternity services and medication at no cost. This financial relief was particularly crucial for women in low-income settings and communities. The availability of free services and quality medication and supplies reduced the economic burden on the families and the women, thus making MLBCs an attractive option for maternity care. MLBCs prioritized delivering respectful maternity care, a critical aspect of healthcare experience for expectant mothers. The respectful treatment offered by midwives in MLBCs fostered trust and confidence, ensuring that women feel valued and supported throughout their birth journey. This respectful approach also contributed to a very positive birthing experience. The clean and well-maintained environment in MLBCs was highly appreciated by women because it is essential for both the safety and psychological well-being of mothers and their babies. Women appreciated the tidy setting of MLBCs. The cleanliness factor played a crucial role in attracting women to MLBCs over other facilities, as it contributes to a positive and reassuring atmosphere during childbirth. The reputation of midwives working in MLBCs was a compelling factor in women's decision to choose MLBCs. Midwives were often recognized for their expertise in providing maternal care and their compassionate approach to women. This reputation could be built over time as positive experiences shared by previous clients contributed to the trust and preference for MLBCs. The geographical accessibility of MLBCs was one of the paramount important factor, especially in regions where healthcare options were limited. MLBCs were strategically located to serve communities, ensuring that pregnant women would access care without facing lengthy or challenging journeys. The convenience of reaching an MLBC was a decisive factor in choosing MLBCs. MLBCs offered a holistic approach to maternity care, providing services ranging from antenatal care, postnatal care, deliveries, and essential laboratory tests. This integrated approach ensured that all the necessary services and care under one roof, reducing the need to travel between multiple healthcare facilities. Beyond medical care, MLBCs also focused on family counseling. This includes offering guidance on diet and health for both the mother and their babies. This counseling aspect is crucial for promoting maternal mental health and infant well-being and fostering informed decision-making within families. MLBCs also extended their services to encompass family planning, providing access to contraception and family planning information was vital for women to make choices about the timing and spacing of their pregnancies. This service contributed to reproductive health and empowered women to control over their family sizes as well as the timing of their pregnancies. MLBCs recognize the importance of post-abortion care, where the management of abortion complications were managed. Family planning counseling was provided with the provision of family planning commodities to avoid further unintended pregnancies and recurrent abortions. Providing comprehensive post-abortion care ensured that women received appropriate treatment, counseling, and support during a sensitive time. In some MLBC settings, they went a step further by offering home birth services. Furthermore, the midwives paid home visits to encourage women for antenatal visits. This feature was particularly beneficial for women who had challenges in accessing maternity care and who had mobility restrictions. Home services brought maternity care directly to the doorstep of women, ensuring that no one was left behind in receiving essential maternity care. Next, please. The care provision at MLBC was client-centric. MLBCs prioritized a human and compassionate approach to care, ensuring that women are treated with empathy, dignity, and kindness throughout their maternity journey. The care provided at MLBCs was women-centric, focusing on the unique needs and preference of each woman. Family members were involved in the care, especially during childbirth, and women were allowed to deliver in whatever position they preferred. Moreover, clients were allowed to have a female relative or partner in the labor room. This personalized approach recognizes that every woman's experience is distinct. MLBCs maintained strict privacy standards, safeguarding the confidentiality and personal space of women during their maternity care journey. In some settings, no male members were allowed in the examination area. This commitment to privacy enhanced women's comfort and security. Women were actively encouraged to ask questions and seek information about their care. This open communication fostered a sense of empowerment and ensured that women were fully informed about their health and choices. Midwives in MLBCs were fully committed and actively engaged in providing care, especially during childbirth. Their dedication and involvement ensured high support and expertise throughout the birthing process. MLBCs offered customized care, recognizing that each woman's needs and circumstances are unique. Tailoring care to individual requirements certified that women received the most appropriate and effective care for their specific situations. Next, please. Women at MLBCs explained the quality of care in various aspects. The first one is the trusted care provision. Women highly valued care that they could trust, and midwives were perceived as experts in their field. Trust in healthcare providers plays a crucial role in the overall quality of care received. Effective communication is a fundamental aspect of quality care. Women expressed the importance of clear and unhindered communication with midwives, ensuring that language does not become a barrier to understand and receive care. Women also appreciated the provision of quality supplements. Although in other facilities, the supplements were provided free of cost. However, they appreciated the quality of supplements they received from these MLBCs. They appreciated the availability of multivitamins and essential medications, which contributed to their overall well-being and health of their babies. Next, please. Some MLBCs went beyond standard maternity care by offering additional services, for instance, ultrasound. These services enhanced the comprehensive nature of care and contributed to more informed decision-making. MLBCs prioritized counseling to address various aspects of maternal and infant health. This includes guidance of dietary choices, breastfeeding support, and hygiene practices. Counseling plays a crucial role in empowering women with the knowledge and skills necessary for their and their baby's well-being. The round-the-clock availability of midwives was a key feature of MLBCs. Women could access services anytime, ensuring that their healthcare needs are met promptly, even during emergencies or outside regular working hours. So we can have the summary. To summarize, MLBCs are perceived by women as offering high quality care when respectful, compassionate, women-centered care is prioritized, midwives are competent, cultural and language barriers are removed, the buildings are easily accessible with good location and 24/7 availability. Women also appreciate being able to access a wide range of services under one roof and being able to access care when they cannot afford to pay for it. Now I would like to hand over to Sheila to continue with the next session. Thank you very much.
Thank you so much, Razia, for that. And it's wonderful to hear the stories coming from the clients and what they appreciate about that care. I'm going to switch slightly, but first of all, let me greet you all. I'm Sheila Clough. I'm an associate professor at the University of Cape Town in South Africa. I'm a midwife, educator, and researcher, and have been leading the South African team in this study. I'm presenting on one of the 4 key findings of the case study, which is collaboration, coordination, and referral. The findings are drawn from the 16 sites in the 4 countries, but I'll be illustrating these findings with examples that are familiar in South Africa. So as the theme of this section is collaboration, I want to specifically acknowledge my colleagues who have collaborated with me in putting together this particular presentation. They are Professor Karen Minney from the University of the Western Cape, and Sonia Walker and Jason Marcus from my own institution, the University of Cape Town. Next slide, please. So looking at the status of midwives, we need to know who the midwives are. In South Africa, they are registered with the South African Nursing Council as midwives, having successfully completed a recognized educational program, including clinical skills. They have opportunities for advanced or postgraduate studies. Their scope of practice is defined and described by national regulation, and they are responsible and accountable for clinical decisions and practice. They may also work as independent practitioners with their own practices. Next slide, please. Looking at the types of MLBCs that we have in South Africa, you need to know what they are. The main type that we have is what we call a midwife obstetric unit. The first ones were established in 1973 and were originally standalone. Many of them have now been developed on the same site, but are separate from the local comprehensive health center, which is a primary facility. This does not have an obstetric or neonatal specialist service, but consultation is possible with specialists at the referral hospital who are known to and themselves know the midwives. The scope of the MLBC covers the continuum of pregnancy care from diagnosis to postnatal and newborn care, including labor and birth. A more recent innovation is the on-site midwife birth unit, which we refer to as an OMBU, which offers labor and childbirth care only. It is on the site of a secondary referral hospital, usually in a separate building, but with easy access to obstetric and neonatal units. When women arrive in labor at the hospital, they are triaged to proceed to the OMBU or the hospital labor ward as appropriate to their health status. This takes away the need for transport during labor if a referral is required. And it also results in cost efficiencies where women who don't need secondary obstetric care are not occupying space that is required by someone else. Next slide, please. I'm now going to take you through the referral pathways that we have in Cape Town, because critical to the integration of the MLBC into the health system is safe care for the pregnant women and neonates. So we have clear referral pathways and guidelines about what can safely be offered at which level of care, and these facilitate appropriate referral. In this diagram that you see, the yellow blocks show what we call the MOUs or the MLBCs. They can refer directly to a secondary referral hospital, which are on the dark blue blocks. During pregnancy, they could be referred to a primary level hospital for non-obstetric issues. Under certain circumstances, the secondary hospital may be bypassed and referral made directly to the tertiary hospital, which is in the red block. We also have basic antenatal care clinics, the light yellow block at the bottom of the referral tree, which refer their clients to the MLBC at 36 weeks. This is all supported by referral criteria, which are negotiated and agreed by midwives, obstetricians, and neonatologists, and critically, are known to everybody working in the service. The referral criteria and protocols are strictly adhered to, and there's an obligation to accept referrals from midwives unless the facility is full, in which case the designated receiving facility must find an alternative place. This quote from a client reflects her understanding about how this works. What I liked about this clinic is that they quickly are able to see the problem if you have it. Then when they see it is not theirs and they will not be able to help it, they are able to refer you to higher people who will be able to help you. And that's pretty much sums it up. If we can move on to the next slide, please. As I mentioned a little bit earlier, we need to have guidelines and protocols to support the functioning of the system. And we have national guidelines for primary maternity facilities and provincial guidelines and protocols for the management of commonly encountered maternal and neonatal complications, which are developed together with all the professionals involved. These include decision-making about the appropriate level of care at any time, and referrals can be effected at any point where a problem or complication arises. This quote from a midwife sums up the usefulness and support of these referral criteria. I was going a bit too fast for the slides. So this quote from the midwife says, "We do have written guidelines and protocols in labor ward and in the antenatal clinic that we follow, especially when it comes to transfers, what to transfer, when to transfer, so we work according to the protocol." Next slide, please. Looking specifically at local cooperation and collaboration, we have cooperative and supportive leadership by related professionals in our area. We have monthly meetings which include all the MLBCs and the secondary and tertiary hospitals, as well as the emergency service management staff. We have audit and feedback, which occurs regularly at each MLBC in a climate of respect and shared problem solving. And this is done by the midwives in conjunction with the rest of the team. Actions are identified and assigned. We have a perinatal problem identification program, which we call PIP, and this facilitates data capture and analysis. And I'll talk a little bit more about that in a moment. And then the last piece about local cooperation and collaboration is about good relationships, and trust is strengthened between sites and individuals through all of these different activities. I just thought I'd pause a moment and speak about the perinatal problem identification program, which might not be familiar to many. It is a simple, user-friendly, computer-based system where the important maternal and perinatal data are entered. For example, the number of births, stillbirths, early or late for neonatal deaths and maternal deaths, gestational age, birth weight. It's a tool to make perinatal and maternal death audit easier. It doesn't do the audit for you, but it takes out the tedious paperwork of the process. And the moment that you enter the basic data, you can instantly do an extensive data analysis and even present your data in graphs and print reports, all with the press of a button. Calculations such as perinatal mortality rate, avoidable factors, and low birth weight rate are given. And this is a standardized program that is used throughout all 3 levels of the service. So we are very familiar with what it can do and how we can use it for interpretation. And I do just bring this to your attention because it's a wonderfully easy program to use, but is so effective in being able to get your data in a way that you can understand and can present to other people. Let me move to the next slide. Thank you. On national collaboration. And at the national level, we have a National Committee for the Confidential Inquiry into Maternal Deaths, which presents annually and triannually a Saving Mothers report. We have the PIP program, and that is presented as a report called Saving Babies. And we have the National Perinatal Mortality and Morbidity Committee, NAPEMCO. These committees consist of midwives, obstetricians, neonatologists, anesthetists, nurses, policymakers, program leaders, academics, and public health specialists, and probably some others along the way, but those are the people that are largely involved. And all 3 reports look at identifying avoidable factors, which might be geographic or level of care, identifying deficits in clinical management, identifying key conditions affecting women and newborns, and then making recommendations and policy implications. What then flows from this is some of the recommendations and policy developments based on these reports. And I'm just going to give a few examples of how these have been applied in the MLBCs. For example, a commitment to upscaling the MOUs, as well as the introduction of the OMBUs, the on-site birthing units. So something that started small as a local initiative has become now something that is recognized as a national policy requirement to be upscaled throughout the country. There's a commitment to respectful maternal care, and there's the inclusion of perinatal mental health in our guidelines. There's the ESMOE training rollout. ESMOE stands for Essential Steps in the Management of Obstetric Emergencies. And one of the things that has come through this policy is the promotion of the use of the non-pneumatic anti-shock garment to prevent obstetric or to treat obstetric hemorrhage and hypovolemic shock. And I'm happy to speak more about that later if anybody wants to ask questions. A couple of other initiatives that have come through as policy requirements are the Helping Babies Breathe training program, extending NIMART, which is Nurse-Initiated Management of Antiretroviral Therapy, to the MOU level, and the inclusion of emergency services and perinatal meetings. At this level of care, the MLBC, these recommendations and policies address some of the big issues and interventions that are required, which are identified in national reports. Decreasing HIV and AIDS, which is a big issue in South Africa. Decreasing obstetric hemorrhage, preventing asphyxia, health worker training and support, and health system strengthening. So you can see that filters through all levels. Of course, we need to have ongoing professional development and ongoing development of skills and clinical judgment. And to this end, we have inter-facility and interdisciplinary outreach from referral centers to the MLBCs. There are skills refresher courses, including ESMOE, as I mentioned earlier, and neonatal resuscitation. We have an annual training day at each of the MLBCs for all staff. So basically all operations in that area close down, except for intrapartum care, and there's locum staff appointed for that. But all the other regular staff would be able to attend the training day. And then there's continuing education options, either online or paper-based, with a locally developed perinatal education program, which is very accessible and very easy for people to run in their own units. And you can see on the right-hand side, I've put a few examples of some of the units that are offered in the perinatal education program. A link to this resource is available at the end of the presentation, and we'll put that in the chat box. So in summary, the MLBCs require well-trained, competent and licensed midwives working in a supportive, collaborative, transdisciplinary networked environment with clear and mutually understood practice guidelines and referral pathways, with a commitment to auditing and improving care, and a commitment to ongoing professional practice development. I conclude with a quote from a leader in maternal and neonatal health in one of the Uganda sites. The common goal that we are having, no mother or child should die. Teamwork is key amongst all of us in the midwife fraternity. Thank you, and back to Caroline.
Great. Thank you so much, Sheila. That was fantastic. And to both you and Razia, thank you so much. Really interesting to hear I think the diversity of the kinds of services that we see in Pakistan, you know, from only antenatal care to only labour and birth care to the whole continuum of care, including access to family planning and other supports. I think that's really interesting. And I think Sheila's given us a very good example of all the interdisciplinary and cross-disciplinary and multidisciplinary systems and processes around the MOUs, the obstetric units, or MLBCs. And I just explained, Sheila, in the chat that the obstetric word is from when you first started them in the 1970s. So it doesn't mean that they're obstetricians there. It's just the word. So we refer to them as midwife-led birth centres in this work. So we're just going to do a couple of polls now. So when I was thinking about these questions, one of the things I think about quality of care is that women have a companion of their choice in labour. And we have lots of research now showing that this is a real element of quality of care. So I'm just super interested in whether the facility you work in, if your service provides childbirth care, how many women are able to have a companion of their choice during labour. So Bruna will put up the questions. So if you work in a health facility that provides childbirth care, how many of the women receiving care have the option to be accompanied during labour by a birth companion of their choice? And of course, you're just going to guess. You haven't got time to go and look at any data, but just a guess, an estimate. Is it all? Is it most? Is it some? Is it none? Or is it not applicable because your service doesn't provide childbirth care or where you work? So I'll just leave that up for a moment and give you an opportunity just to give us a sense. There's no right or wrong. We're just really interested because we know companionship's associated with women saying they had quality of care. And just while that's coming up, we're not providing certificates for these seminars online. It's really too difficult to do that. So if you're in a program with the CPD where you have to keep track of your CPD hours, we just recommend that you keep a log of that you listened and you were part of this webinar series. So Bruna, let's see. Oh, very good. So a third of you all, another fifth most, another third some, and really interesting that only about 1 in 10, about 9% say no companion of choice. So that's really encouraging. That companionship in labour is really becoming much more prevalent across the world. All right, let's do our second poll and then we'll do some questions. So one of the issues that Sheila talked about was this issue about interdisciplinary referral, having policies and protocols that guide your process of referral. So we're interested in whether you have these. So if you work in a health facility that provides childbirth care, is there a formal policy or protocol that guides the process of referral to a high level of care where needed? So we'll put up the poll. And of course, you might write not applicable if this is not relevant to you. You might be working in the hospital where the referral comes to you. So maybe think about the protocols that guide the referral of other people to you. So the options, yes, and it always works. Yes, but it doesn't always work. No, and not applicable. So again, just get you to have a look at that question. Okay, so almost all of you have a referral, but about referral policy, but about half don't always work as well as they could. So I think that gives us all something to work on, doesn't it? It's all very well having a policy, but if the policy doesn't work, then we need to change the policy or strengthen the policy. All right, so thank you, everybody. Let's just go to some Q&A. We've got about 15 minutes left, and I can see my colleagues have been answering your Q&A as we go along, which is just fantastic. And I'll get to, there's some French ones in a minute that I'll just get to in a moment. But Razia, I wonder if you would, you've been writing in the chat about the way the services in Pakistan are funded. And I just think many colleagues would be really interested in the funding model, the private-public partnership model in Pakistan. I wonder if you would just speak to that for a moment. You've written some great things in the chat, but I know that some people would really like to hear from you. Are you able to jump off mute and tell us? Maybe not. Okay, so for those of you interested, oh, you're there, lovely, great, thank you.
So if you talk about particularly our study, so the provision of services were free in sites where the MLBCs were established through public-private partnership. In public-private partnership, usually some NGOs or INGOs, they actually take care of the operational cost of the MLBC. However, the building is of the public, it stays with the public, and the operational cost, the salaries, the supplies, equipment cost, everything is covered by that particular funding body, be it a national governmental organization or INGO. So in that case, services were provided free of cost. Second model where the MLBCs were operated by midwives only, which we call them as standalone. And in those cases, in those MLBCs, clients were provided free services, free delivery services, plus medication and supplements, where the women were unable to afford. Talking about the context and socio-cultural norms of Pakistan, it was appreciated by the women who were unable to afford to pay the delivery fee to the midwife, and the midwife, they themselves were providing free care, free services, and in some instances, they were providing dresses and blanket and clothes for the newborn, along with some food basket for the needy women. If you talk
Great.
about in generally the health system or the insurance, because somebody asked about the health insurance system in Pakistan. So before 2018, there wasn't any kind of health insurance per se, because there are like public providers, service providers, and private providers in Pakistan. In public health facilities, all the services are provided free of cost. However, in private, definitely there is out-of-pocket expenditure. But in 2018, the government took initiative and they introduced Sehat Card. That was kind of a national insurance scheme where the people who were below the poverty line were able to access health services, both from public and private providers, up to initially it was 1 million, and then they increased the amount up to 2 million. The Sehat Card program initially started in KPK. However, in 2020 and 20 onwards, they expanded the services to other provinces of Pakistan. I hope that answer your question.
That's fantastic. Razia, just one more question before I go to Sheila. One of the French colleagues has asked, in the private models, does a doctor need to be involved, or can it still be the midwife as the lead?
In private MLBC, if you talk about private MLBC, definitely it's all operated and managed by midwife.
Great.
So there are
Perfect.
no involvement of obstetrician or gynecologist. It's solely operated by midwives.
Yeah, I think that's really interesting, the different approaches to the private models. And we saw last week as well, with Rose talked about Uganda, which are mostly private models. Sheila, I'm going to come to you. There's a really good question about collaboration. In an environment where hierarchies are so prevalent, how does one create mechanisms to strengthen interprofessional collaboration? Which I think is a very valid question in many countries.
Yes, absolutely. I think we do need to look at the various contexts in which we work and where we can leverage those opportunities. I mentioned the fact that we do have regular meetings with all the role players, primary, secondary, and tertiary level. And there we have been really fortunate in having obstetricians and neonatologists alongside the midwifery leadership who have really been champions of this type of approach, where they recognize that that's not where their role is, other than to be supportive. And so they support, they collaborate, they work alongside us in terms of developing protocols in the same way that we work alongside them when we're looking at protocols for high-risk women at secondary and tertiary level. But I think it's developing those relationships is so critical, and looking at who might be the champions in your area that you could use to be able to influence other people. I think that meeting together is such an important thing. I said in the one slide, I said that the midwives know the doctors and the doctors know the midwives. They know who they're talking to when somebody lifts the phone. So developing those relationships are critical. We also have, as I said, we've got the national and provincial committees, but also looking at where there are people that gather for a purpose, like a conference, or where there's a call from the National Department of Health, to make sure that you take that opportunity to have your voice heard. We have an annual congress in South Africa, which is called Priorities in Perinatal Care. It's largely attended by doctors in the public sector rather than the private sector. And they tend to have a much more public health approach to the way in which they do their obstetrics or neonatal practice. But we are all equal in the eyes of each other at those conferences. And it's a really good opportunity for sharing ideas, developing research projects. I think PIP came out of there. I think PEP came out of there because we've seen the need and we're able to work together, see the people who can bring their strengths to bear on things. So I'm not sure if I've gone a bit off topic. Can Can you help
No,
me?
that's great, Sheila.
Okay.
Just while you're still talking, there's a good question about has supporting MLBCs increased the trust in the midwife from the community? Because I think it's that, for me, it feels like that trust is so important from the community. And then there's the trust, the interdisciplinary trust. Do you think that, and you've been going for a very long time, so clearly this is working.
You know, I think I'm going to speak first about the public sector. I think the trust is there more so than in the private sector, and I'll clarify that. Because people are working together at primary, secondary, and tertiary levels. We have the student midwives and the student medical students working in these facilities to, you know, to be exposed to primary level care. So they know that from the time they are students. And all the time that they're in the public sector, the leadership are constantly reinforcing the importance of supporting midwives. I mean, one of the neonatologists says to her, needs a referral, you may not say no. You must listen to her. She knows what she's talking about. You must accept the referral. That level of passionate support that is demonstrated on a regular basis is so important. When one gets to the private sector, I haven't worked, you know, exclusively in the private sector in South Africa, but I think that's where it is more challenging. And I know that the one site that we had, which is a private sector site, and I know there are some people on the line today, they have good relationships with both public and private institutions, but it is more challenging to find private support. And linking up with the question that was posed to Razia earlier, in South Africa, our legislation, which is the scope of practice for midwives, says that a midwife who is looking after a client in pregnancy must ensure that she's seen at least once by a medical practitioner. Doesn't say an obstetrician, must be seen by a medical practitioner. So that there is that backup in case there are issues around anemia or malaria or whatever that might be. And that would then be an expectation that one would be looking for backup support from a doctor in case there was a referral. And I think that is often the place where our colleagues in the private sector struggle, because the private obstetricians have huge pressures on them from the insurance companies and the medical malpractice insurance companies about whether midwives can be linked with them at all. And that is a huge systemic issue, but it's an issue of economy and not an issue of professional practice. Because looking at our professional practice figures, the midwives figures are far and away much better than the others.
Great. Thank you so much, Sheila. We're running out of time, so there's lots of really great questions. And I think this issue about the respect for midwives and the respect for what midwives can do is one of the really common threads I'm seeing. And I absolutely agree. There is much more work to be done around advocacy, around support, around kind of having the evidence that yes, midwives can do this, and we hope to we will show you next week in the webinar about the cost effectiveness of these midwife-led birth centers. So they really make a difference to cost, and of course all of our services are interested in cost. There's one question that I'm quickly going to answer, and that was about how do we integrate midwife-led birth centers into midwifery education. And I've got two comments quickly. One is that we should allow midwifery students to have their placements in MLBCs so that the students see the practice of the midwives right from the beginning. And the second one is that midwives should practice continuity of care as students. So many of the countries are starting to have continuity of care as a requirement for students. And there's some very good literature around this that we can share, but I think that's a real trick to embed from the beginning. So Bruno, we might go on to the last couple of slides in our last 2 minutes. Thank you everybody for your fantastic questions and for your engagement. We have more than 200 people online, and I'm sorry we can't get to all the questions. We did have a question about how we're going to help midwives around the world start MLBCs. The WHO is developing an implementation guide for countries who want to start MLBCs. So that will come out next year. It's called STAGE, which is the scientific advisory group for this work out of WHO. So please look out for that, and we'll talk more about that in the next couple of weeks. So next week, we're talking about cost effectiveness, and please encourage your policymakers to join us. The people in Australia, we call them the bean counters. I'm sure you have your own terms in your own countries. Please encourage them to join us, because this is really where it becomes important about implementation. So we're going to talk about our cost analysis, our methodology, and our findings. And you have 3 new speakers. Martin Boyce, Emily Challender, and Vanessa Scarf will join us next week for this fantastic session. So thank you everybody so much for joining us today. My apologies for the time difference changes. If you have missed, if you're just joining now and you've missed, you can get the whole webinar on the ICM website. Thank you very much to our interpreters for keeping up with us. And thank you to all of you for joining us for this webinar. See you next week. Bye-bye.